Yesterday I mentioned this strange word 100,000 voltage. Today it's 200,000, but at a much calmer transmission level. Before starting a discussion, many points of discussions come to this residual gradient. And we should define this very precisely. Is it a clinical gradient, or are these velocities measured by echocardiography? And we all know that every intervention and surgical intervention change the axis somehow of the aortic arch, which reflects in different velocities. So I ask you to define residual gradients, because many misunderstandings may come from this point.
Okay, both of you, quick answer. What do you reckon is a significant residual gradient?
Residual gradient is a difference between arm and leg pressure if you say the arm and the leg arteries are okay. That's a clinical definition. I think significant residual gradient is for sure more than 20 millimeters of mercury. Maybe we should have even lesser gradient, but less than 20 is a problem of measurement, because the measurement is not so precise. But residual gradient is only one problem we heard, and I like that very much. The more appropriate problem would be brachycephalic hypertension, regardless of stiffness or gradient or any other
Victor,
reason.
when you operate, after an operation, when you're finished, what would you reckon is a good result of yours in your hands? Residual gradient of zero, ideally?
There should not be a gradient, but sometimes you see the gradient because of the hyperplasia of the arch, which basically generates this gradient. But it's very true that we don't have a good protocol how to assess the gradient. Yeah? We don't have at all, because the Doppler measured gradient is not reliable. The peak-to-peak measured gradient, okay, but who is doing that in the follow-up? So what we rely on is just the arm-to-leg pressure gradient, and this is not good enough. So the point is, yes, we accept that 20 is a pressure gradient, which is, should be considered for some kind of treatment. However, we don't have a methodology how to properly measure this gradient.
Okay, so let's move on. You wanted to show a slide?
Yeah. Before I show the slide, I want to congratulate you to your talk. And that's not only because I like you, but also because you showed us beautiful color pictures. And we, interventionists, are the only ones who stick with black and white still. Even the MRI people have beautiful color pictures right now, but we don't have them. And I'm very sorry for that. Regarding the timing of the procedure, I couldn't agree less with you. I couldn't agree more with you, sorry. I think early intervention is very important, but we have a lot of patients who are not recognized before a certain age, and you showed that beautifully. What I disagree with you, do you really think the preparation of such a long segment as you showed us will leave the wall completely normal? The wall of the aorta, after such extensive preparation of the wall, will be completely stuck in scar tissue, not only where you do the suture line, but the entire segment which you open up and where you take the aorta out of its natural surrounding. And if we want to preserve the compliance of the aorta, then we have to do as little damage to it as possible, and that would be a balloon. And one other question, why...
Well, let's hear it from Viktor straight away. What do you think to his comment?
Well, it's a black and white situation.
Then another...
No, Viktor, so you disagree with him or what? We want to learn from you. Tell us.
The dissection itself, of course, creates some kind of a reaction around. There's no question about it. But if this is true, we couldn't operate at all, nothing, you know. And everywhere we would have an enormous amount of scar formation and so on, which is not the case. So what you saw on this stenting, because probably you are referring to this video where I showed the stent, I said that this is not a coarctation. It was just a diseased arch. So it's not a good example, I said that. But what I showed, the coarctation, simple coarctation repair, yeah, this segment is mobilized. However, the damage of surrounding tissue is minimal because you are dissecting in the layers. You are not dissecting across the layers. So it's in the layers and everything is healed appropriately afterwards.
The last question I would mention is why nobody discusses recoarctation. Everybody agrees to treat recoarctation by ballooning, by stenting, despite the results are not different from native coarctation. But in native coarctation, the surgeons say, we have the better solution. Only in recoarctation, they agree to do ballooning and to do stenting. I'm convinced the scarring makes redilation more effective if you do only a balloon, and maybe it lowers the risk of aneurysm formation because there is already a scar. But in the terms of gradient, it's not different, and nobody discusses redilation, and no surgeon is keen to do redo surgery. But the timing is the most important thing, and I agree completely, and that's my conclusion outside of a pro and con decision. I think the indications are clearly stated. We both have the same indications. The type of intervention in circumscript coarctation is, for my liking, surgical interventions for all neonates and young infants. And we can discuss what is a young infant, and some centers have 6 months as the time. In Leipzig we have 3 months at the time, but as long as the ductal tissue is reactive, as long as it's not a scar, then the ductal tissue is a scar in itself. As long as that's reactive, I think it should be a surgical procedure and you should take out this reactive ductal tissue. Balloon angioplasty, I think you should do beyond that certain age of young infancy, because if you have a chance of more than 50% to do only once a balloon dilation in the life of the patient, then that's the less aggressive method compared to surgery and compared to stent. And in the other 50%, we can discuss to put in a stent or to go for surgery or whatever. But if I can give half the children a good prognosis without re-intervention, with only a balloon, then that would be my choice. In long segment coarctation or coarctation associated with hypoplasia of the arch, I think we should do surgery in younger children, and I think we should put in stents in the large children where we can reach adult size of the stent either immediately or with one redilation. Maybe we will have a different type of stents in a short or longer time, which is resorbable, which will not make this inflammatory reaction, this ingrowth of tissue. Then maybe we have another situation. So far, that's still not developed far enough. And in post-surgical and post-interventional recoarctation, I think we should start with ballooning again and put in stents in larger children. So I think that's a little bit more tolerant than what I did before, but I think balloon dilation still has a place and shouldn't be regarded as out of the picture, as you said.
I think. Thank you.
Should we allow one question in between?
Can I have this, my slides? Can you, maybe I should just close it.
Should be still open or not?
Probably one question in between. You are waiting so long.
Yeah, to Dr. Daehnert, one of your best arguments, and coming again and again, is the short hospital stay. But if you add to it all the hospital days that the children are coming for re-intervention, you are not far away from the hospital stay time after surgery. And the second thing is that the parents, that they know that the kids are going to go to the hospital again for re-intervention after stenting or balloon, they are busy with it for years. So this short hospital stay is not true very much, and it's quite difficult for the parents, the years after.
I think, sorry, let us not, excuse me, Professor Daehnert, let us really have a true discussion here, pros and cons. I think you made a point with this hospital stay. How about you? What feeling do you have?
Just one comment. The conclusion you have is pretty exactly what is published in the common guidelines of the German Society of Pediatric Cardiology. Comment number one. Comment number two is, what both of you missed is the discussion about the residual gradient. In the guidelines we have a statement that the size of the coarctation of the aorta should be, and there is published data for that, about the size of the aorta, the descending part at the level of the diaphragm, because that's the normal size. And whatever we discuss about residual gradients, 20, 15, 25, whatever it is, as long as this size is not achieved, you will have some form of flow obstruction, and you will have, specifically under exercise, some form of hypertension, brachycephalic hypertension. And I think that is one of the points, whether you do surgery or stent, the aim should be a normal size aorta for the long term. And whether it is stiff by stent or stiff by surgery, I don't think there's a big difference.
Yeah, thank you. I prepared several slides for this rebuttal, and this is the first to trigger this discussion, which is already underway, somehow to develop a rational approach to decision making, taking into account the long-term prognosis of different modalities. And really we are very weak in this, in general, because we don't have a protocols for many things I listed. Appropriate management strategy. We don't know. Some believes that stenting is great. I don't think so, because it's like a rigid tube. We don't have a protocol for evaluation of recoarctation. It was right now said, exactly, that probably we should concentrate more on the morphological aspect than on the gradient aspect, which anyway we are not able to measure properly. So if there is a low threshold to consider situation as a recoarctation, the MRI probably should follow to see what's going on, or not only of aorta, but MRI of aneurysm in the cerebral areas and so on. So we really need a protocol for this simple disease, which will be pretty complex. We need have a system for the early recognition of hypertension. Do we have it? I don't think so. We don't have even a protocol for appropriate medical treatment of hypertension at this point. And we don't know when and how to intervene and how to respond to exercise-induced hypertension. So this is job for you. Job for me is to give you a take-home message. This take-home message is not for Berliner. For Berliner, it's the end. So take-home message is, from my standpoint, early prophylactic surgical treatment with targeted antihypertensive agents may prevent irreversible changes, driving the hypertensive response from occurring, and thus improve the long-term outlook for this patient born with coarctation. That's the take-home message. As I said, I have a short version for Berliner, and that is like this.
Thank you very much. I think we should slowly go further. I have a last question to Viktor. It is midnight, the baby is 2 days of age, the ventricular function, ejection fraction is about 30%. I miss it a little because our topic is ventricle under pressure, and we have a simple coarctation. Should we call you midnight, tomorrow in the morning, or 2 months later, probably, if we should think about this result?
I think that it should be multidisciplinary approach to decision making. This is very important. In our institution, if the duct is still open, we would try to keep the duct open and see how the situation develops. If anyway there is a severe LV dysfunction, the guys would put a stent to temporarily release the area of coarctation, and probably surgery would follow relatively soon, let's say a week or so after these interventions. We use this approach in the past frequently, and it works very well. They use a coronary stent, yeah, am I right? They can something like this.
We could do that, but in Leipzig we would be hesitant to put in a stent. We would first see what happens if the duct is open, because if the duct opens up, mostly the gradient is going down, and the left ventricular pressure will function will recover at least as good that a surgical approach can be done during the next, I think, 24 or 48 hours. But it really depends on how the function is recovering.
Yeah, so there is agreement.
Thank you. Dr. Ebert, please.
I just wanted to make a comment. It is not the question whether we use surgery or stents or balloons. It is a question to control the blood pressure. And to say that this is not possible with one or the other method, I think is exaggerated. And we had a cohort of more than 40 adults with coarctation, which we treated, who we treated by intervention. And it was extremely astonishing for me that there is a considerable amount of patients after relief of the stenosis, by stents, of course, they do not need any medication at all. Some of them are, as a reaction of the sudden relief of the stenosis, they are, in the opposite, they are hypotensive, and they have problems in the everyday life to deal with this hypertension, with depressive reactions. And I think we should focus on the control of the blood pressure. And this is an additional comment to that what Nick said. Whether the residual gradient is 10 or 15 or 20 or 25, the decisive thing is, are they hypertensive? And can we control the hypertension by medications, or should we deal with the residual gradient? And whether you have a stent or you have a scar, the pulse wave will be interrupted anyway in the aortic arch.
Well, can I answer?
Yeah, we just have to bear in mind that we are a bit overdrawn already. Let's give it another 5 minutes, and then we have to move on.
Just shortly, Peter, your department published opposite result. That's what I used. Munich published that only few patients after successful stenting remain normotensive, just few. Let me finish. Okay, so they publish simply that, and that's how it is. Because what we should, these are the data which I use for this argument. On the other hand, it's a common sense that stiffness aorta is simply stiffness aorta. And scar itself doesn't create stiffness aorta. That's not true. What is stiffness after surgery is big patches, Vorschulterplasty, or tube, or something like this, but not end-to-end anastomosis, which is the best what can be done for the coarctation, or ballooning maybe, but in very, very selective cases, probably. So, yes, the issue is hypertension, and issue is how to prevent the occurrence of the hypertension. And that was my point, to operate as early as possible.
Right.
Nick and Peter, you both are right. But our topic was, do we still need a surgeon?
Yeah.
Professor Berger, question, please.
Well, I personally have the impression that you both are doing a great job, and your discussions was excellent in both ways, and I understand it totally. So, but at your rebuttal, Viktor, I was a bit confused, because you listed we have to build up protocols for a follow-up, we have to do investigations with the blood pressure, and that what me confused, that was your last sentence to that slide, and that is job for you. So, if we do that job, and we had the conclusion we already heard and was published by Ingo Daehnert slide, the last slide, then it would be our conclusion, and then you, oh, that wasn't that what I meant. How we should deal with that?
Yeah, that's why you need a surgeon, you know, to have a... No. No, together we have to work on this issue. Together, of course, it's for the sake of fun.
We think it's the last question for this discussion. Thank you, please.
Well, to sort out this question, the long-term results, of course, the most important thing, and for the long-term outcome, the residual gradients is an issue. And the experience we made, especially in those kids after a nodal operation, hypoplastic left hearts that we had in the cath lab at 3-4 years of age, we found no gradient at all during echo and during cath. But if we used now to stress, we stressed them with dobutamine during cardiac cath, and then the gradient appears. So there is a significant number of patients that have no gradient between upper and lower extremities, but when you want to stress them, these gradients appear and they have significant residual correctation that responds nicely to dilatation then.
Yeah, this is a very important point. I think this is behind of our unsuccesses in hyperplast. This point that some hyperplasts are coming back with burnout right ventricle. We don't know why, and this is I think why, because the whole arch is just a tube. It's a stiff tube because we use autograft tissue, which is after months or so extremely stiff, and that's what creates this response. Yeah, thank you.
Thank you very much for both speakers. We are happy that